Welcome to Lesson 4. We will consider the assessment and treatment of encopresis. And the verse guiding this lesson is from Psalm 25, verse 5. Guide me in your truth and teach me, for you are my God, my Savior, and my hope is in you all the day long. Encopresis is a disorder that involves the voluntary or involuntary passage of feces in inappropriate places in a child aged 4 years or older after organic causes have been ruled out. Functional constipation is often associated with encopresis, and the diagnosis of encopresis must include 2 or more of the following in a child with a developmental age of at least 4 years with insufficient criteria for diagnosis of irritable bowel syndrome. So the child must have 2 or fewer defecations in the toilet per week, at least 1 episode of fecal incontinence per week, a history of retentive posturing or excessive volitional stool retention, a history of painful and hard bowel movements, the presence of a large fecal mass in the rectum, history of large diameter stools that may obstruct the toilet, and the criteria must be fulfilled at least once a week for at least 2 months. Encopresis can involve non-retentive fecal incontinence, and it must include all of the following in a child with a developmental age of at least 4 years: defecation into places inappropriate to the social context, occurring at least once a month, no evidence of any inflammatory, anatomic, metabolic, or neoplastic process that could explain that, no evidence of fecal retention, and the criteria here must be fulfilled for at least 2 months. Encopresis is a common disorder that can affect 1 to 3% of children over the age of 4. It can occur in a chronic pattern as well as an intermittent relapsing pattern, and occasionally a child will suddenly display a spontaneous remission. There are usually daytime occurrences of this behavior. Nocturnal behavior is often related to an organic cause. Boys are more commonly affected than girls, and it's normal for a child to have 1 bowel movement a day, but in children with encopresis, more frequent bowel movements are common. Fecal incontinence after the age of 4 can be associated with encopresis. As well, children with developmental delays or a history of a difficult temperament have a higher incidence of encopresis. Moms with depression or anxiety disorders are more likely to have a child with encopresis as well. So that's another associated factor. Functional constipation or genetic factors related to um, constipation can also be contributing factors. Acute constipation, psychological stressors, anal fissures, a change in diet, intense toilet training, or side effects from medications are additional causes or associations with encopresis. So 30 to 50% of kids with encopresis also have another psychiatric comorbidity, such as separation anxiety, a specific phobia, ADHD, generalized anxiety disorder, or most commonly, oppositional defiant disorder. The Bristol stool chart is one of the most helpful visuals for assessment of bowel changes. And it's really important to understand when a child has encopresis if they're dealing with any constipation or any issues with liquid stool. And so here is a little visual of the Bristol stool chart. And assessment and diagnosis for encopresis involves the, of course, detailed history and physical exam. So you're looking to assess for any impaction or constipation, bowel tenderness, or abdominal distension. And of course, it's helpful to have a pediatrician or primary care provider to do a rectal exam, and an intake and output diary is helpful. And usually, if you're having a child that's been dealing with some chronic encopresis, you're going to need to order a abdominal ultrasound or x-ray with contrast. And um, as well, you need to consider for your differential diagnoses chronic constipation, anal fissures, Hirschsprung's disease, as well as other organic causes such as um, cystic fibrosis, hypothyroidism. And so it's just important to consider any possible organic cause that's contributing to the problem. Treatment of encopresis involves, first of all, psychoeducation. It's really helpful to first of all, alleviate any sense of guilt or shame or stigma, because many times a child may feel that it's their fault, or, there's something wrong with them. And it is a difficult problem. There's often a lot of conflict in the family because of the just the difficulty that comes with cleaning up a stool, incontinent stool, whether there's purposeful smearing of feces or just cleaning underwear and other items. So it's important to help educate, because often, even if there is an emotional component, there's often a secondary physiological response. So frequently, there is some constipation that develops from the stool retention, or um, withholding of the stool, so that it kind of builds up and it gets hardened, and then liquid stool kind of like comes in across over the impacted areas. And so it becomes a physiological problem, even if there is a psychological problem that is triggering it. So psychoeducation is really helpful, and it's really helpful for the child and family to learn that it's not a willful thing, that it's not just the child is doing this purposely, and that there is either an underlying psychological distress, or and actually a physiological response. So, really helping to achieve a therapeutic relationship is key, and um, definitely helping the parents with some behavioral approaches because punitive responses to encopresis actually strengthen it. So we know that negative reinforcement actually makes things stronger. So it actually can perpetuate it and make it worse. So really behavioral parent training is so important with these families as well. Now, nutritional interventions are key as well because we have to increase fluid and decrease and fiber, both. And so, actually, that's why I think psychiatric nurse practitioners are one of the best mental health providers to treat encopresis because we understand both the physiological as well as the emotional connection here. Now, the best approach for treating encopresis is one that, I have coined and used in the past in my years in working with kids is the sit and go program. So the sit and go program involves having the child sit on the toilet 3 times a day after breakfast, lunch, and dinner, hence the sit. And so when they're sitting on the toilet, it's best to have some type of a stool for them to sit their feet up so that they have the best posture for defecating. And they are supposed to sit for at least 5 to 10 minutes. And so allow them to have a little book to read or some type of distraction so that they are, able to sit there for 5 to 10 minutes. And sadly, a lot of kids today do use things like a tablet or something, but seriously, something for them to be distracted so they can achieve the 5 to 10 minutes of sitting. And that's all they need to do. So if they sit, they can get a star. So we are using a contingency management program, a star chart, and so after sitting, they get a star. If they actually sit and go, meaning have a bowel movement, then they could get 2 stars. And the stars all need to be reinforced with something meaningful to the child at the end of the day or the end of the week. So it's really important. So the sit and go program is one of the most effective approaches. So treatment of encopresis often involves the associated treatment of the constipation, which is very commonly associated. So oftentimes, the use of Fleet's enemas or laxatives such as Senecot, as well as stool softeners, may be an important part of the treatment program, both the initial as well as the maintenance program. Now, occasionally, when there is any kind of impaction, first off, then treatment with enemas may be important as well. So, close coordination of treatment of encopresis with the primary care provider or pediatrician is usually the standard. Let's consider the following case study. Charlie is an 8-year-old boy who presents with his mother with a history of encopresis over the past 4 years following a very difficult divorce. There had also been some exposure to domestic violence. Charlie has several soiling episodes each day, always without any sensation of urge or leakage. Otherwise, he also will occasionally hide his bowel movements under the furniture or in other unusual places. Lately, he's been refusing to go to school and is worried about something happening to his mother. He has no medical problems and has just been medically cleared by his physician. Children with encopresis often need intervention for the treatment of the functional constipation as well. So we can assume that the pediatrician has instituted some evaluation of this, ordered some imaging studies, or initiated some treatment with laxatives. Now, we see here there's a risk factor for PTSD, as we do see Charlie having an exposure to trauma. And so trauma-focused therapy, play therapy, may be an important component in his recovery. We also see some symptoms that are going to cause us to evaluate for social anxiety disorder or separation anxiety disorder, which is a common comorbidity as well, and which also will need some treatment. However, those issues need to be treated separately from the encopresis. And the encopresis treated first with, again, treating the functional constipation and initiation of the sit and go program. And so, in conclusion, the treatment plan for Charlie will involve a complete psychiatric evaluation to identify any comorbidities, again, such as separation anxiety, as well as PTSD, and need to confirm whether he has been treated for functional constipation or if treatment is needed in that area. And the ACEs interview to really assess the impact of childhood trauma, knowing that down the line, some trauma-focused therapy will be helpful as well after behavioral treatment for the encopresis. So it's not clear here what is his current relationship or involvement with his father, but family therapy is often very helpful in treating children in these situations. And again, behavioral parent training, really helping to remove any punitive approaches related to the fecal incontinence. I mean, it can be a very aggravating problem. You can imagine finding the stool in unusual areas under the couch. And so parents can get very angry and not realize that the punitive approach actually can be causing negative reinforcement of the behavior, meaning making it stronger. And so the sit and go program uses positive reinforcement, and we know that positive reinforcement is much more effective. And so the sit and go program is essential.